Hello, guests. Welcome, viewers, for joining us today. Today is Friday, May 29, 2020. It is noon Central Time or 1 p.m. Eastern Time. Thank you so much for our guests for joining us today in celebration of Public Health Genetics Week, which is the last week of May. And this year in 2020, it is May 26th through 29th. And during this week, we had a lot of great events to introduce the works and activities of public health genetic services that's available to all of you. And during this week, we provide a lot of events for you to understand genetics and genomic information to improve population health, public health, and to prevent disease. And so thank you again, our guests, for being here today. And for viewers who are watching this webinar as an archive, definitely feel free to reach out to us if you have any questions about the webinar. We're happy to answer any questions pertaining about Public Health Genetics Weeks. We can send you to the personnel who are in charge of organizing that week. And if you have any questions about newborn screening, and especially in our organization, the Newborn Screening Translational Research Network. So today I'm very delighted to have our presenter, Dr. Amy Brower, who is the Co-Principal Investigator, Co-PI of the Newborn Screening Translational Research Network. And you're probably wondering, what is NBSTRN? Well, in this webinar, we're going to share with you all the resources that are available to you and what we can do for you. So Dr. Amy Brower, we're very excited to have you give this presentation. And for our viewers, definitely feel free to reach out to us and visit our website to learn more about these resources and how we can connect you to researchers, doctors, and anyone in our network. So Dr. Brower, thank you for being here today.
Great. Thank you, Dr. Chan, and thank you everybody for tuning in. We're really excited as NBSTRN to be part of the first ever Public Health Genetics Week. This Genetics Week has been sponsored by the National Coordinating Center for the Regional Genetics Networks. And the goal of the NCC team in sponsoring this week focused on public health genetics is both to increase awareness about and to celebrate the efforts of professionals in public health genetics. So congratulations to all of you that play such a key role in advancing genetics, genomics, and public health. So my job today is to give you a little bit of an introduction to the Newborn Screening Translational Research Network, but I wanted to take a step back and talk about how the NBSTRN fits in with the mission of public health, genetics, and genomics. The goal in public health genetics and genomics is really to begin to understand how we can apply this accelerating amount of information, both on the genomics front and on the ability to follow health information at a population basis. So we're really trying to improve the practice of clinical medicine through public health efforts. We're especially focused on how we can harness the knowledge that's being generated by new technologies and new approaches to both treating disease and preventing disease. So I was actually a member of the Human Genome. So it was a few decades ago. We were busy at work in trying to understand this book of life. So the spelling of the 3 billion base pairs that we each inherit from our mom and from our dad. So in the late 1990s, early 2000s, we began an effort to sequence every chromosome and to understand every base pair. We thought that with this knowledge, we would be able to understand more about the beginnings of human disease and to begin to plan for targeted interventions to ultimately improve health. So when we think about the human genome and genomes across the world, each of us has a different genome, and each of us have different misspellings in our genome. So we think about genetic changes at the base pair level. We used to think about them as mutations, but we know that, and mutations sort of can have a negative consequence. So you think if you have a change in your genome that's different, maybe Dr. Chan and I differ across the genome on average about 4 million spots across our 3 billion base pairs, we have a difference in our spelling of our genome. We would think if we call it a mutation, that that means you're going to have a disease. But what we've understood through population-based analysis and studies, thanks to public health genetics, we understand that not every variant has a negative consequence or even has a clinical consequence. Some variants in the DNA sequence don't do anything. Some are actually beneficial, so they either help us metabolize a new drug or help us respond to our environment. And some, a small portion of these variants, actually make us susceptible for different diseases, and some can cause different diseases. So we're all about, in the world of genetics and genomics today, trying to understand how these differences in the genome between individual people relates to their susceptibility to disease and to their responses to treatment for disease. The benefit of having public health genetics is that we're able to look at not individual by individual, but we're able to look at populations. And so by looking across populations, thousands and hundreds of thousands and even millions of individuals, we're really able to understand which of those genetic misspellings or differences lead to disease. On average, each of us are born with 6 differences, or 60, sorry, that have never been seen before. So when I give talks to high school students, I always say if your boyfriend or your girlfriend tell you you're one of a kind or you're special, that's really true. There's never been anybody like you born in the world. So we each have 60 novel differences, and those 60 really help set us apart from individuals in our family and from individuals in our community. So understanding variants is a really important part of public health genetics. So when we think about the application of all of this knowledge, both on what the genome says and the new diagnostics and new treatments that we have, we can apply public health genetics across the lifespan. So whether we're thinking about newborn screening that I'll focus on today, or we're thinking about diagnosing a disease, choosing a drug or an intervention for a diagnosed disease, or beginning to try to predict and prevent the onset of disease. So today I'm going to focus on the application of public health genetics in newborn screening. A good example, I think, of newborn screening in the public health realm, because newborn screening really begins in the state public health programs. So every state across the United States runs a newborn screening program. And I think a good analogy to that is the vaccine programs. So the administration of vaccines is also a public health program. And so the goal is to vaccinate or offer a vaccination to every individual that's born in the United States and every individual that grows up in the United States. So we're really trying to not to think about the population good. So we know that vaccines prevent disease. And so on a population level, we want to make sure that everybody has access to vaccinations, whether they grow up in Iowa or Florida or Idaho. It's a public health program so that everybody is offered vaccinations with the goal of saving lives and improving outcomes. Newborn screening for the last 60 years, it's amazing that it's been the last 60 years, is really considered one of the nation's most successful public health programs. Every year, our almost 4 million babies that are born in the United States are screened for anywhere between 30 to almost 70 different diseases. The hallmark of which diseases we screen for is that by detecting these conditions early and intervening, whether it's with a medication or a particular intervention, that we're able to improve the newborn's life. So we're able to save lives and we're able to reduce the effects of whatever disease the newborn has been diagnosed with. So last fall, I had an article in the USA Today that was focused in public health genetics, and I really thought about the unique aspects of newborn screening and how newborn screening combined with genetics and genomics is really the best case we have today to think about precision medicine. So every day, the 12,000 babies that are born in the United States, about 56 of these newborns have a life-threatening or disabling condition. Now, these babies, when they're born, they look perfectly healthy. They pass all of their tests in the newborn nursery, but they have some underlying defect that once they go home, we begin to see the consequences of those genetic misspellings or genetic variations. And so if we're not able to intervene early before symptoms show up, there's irreversible damage that happens to those newborns. So public health applied to the newborn screening realm, where we're able to reach all of the babies that are born in the United States to screen them preemptively for conditions that they might have a bad outcome from, is really a great story. So how do we decide, out of all the diseases that we could screen for, how do we decide what to include in the state newborn screening programs? So in the 1960s, President Kennedy put a lot of research funding through the National Institutes of Health to really try to understand a condition and a disease that was really impacting the United States at the time, and this was intellectual disabilities. So in the 1960s, early 1970s, many little children and young adults with intellectual disabilities, or at the time they called it mental retardation, were warehoused in institutions. And although they were well taken care of, we weren't quite sure what was causing the increase in intellectual disabilities and how to improve outcomes for these individuals. So with research funding at the NIH, there were some studies that were undertaken to try to understand the molecular and biological basis of some forms of intellectual disabilities. And this picture on the left is actually with the little kids, is a picture of a brother and a sister. And this brother and sister have a classic genetic disease called phenylketonuria, or PKU. And this is the inability, because of a misspelling in their genome or a variant in their genome. This is a disability or a disease that leads to the inability to metabolize an enzyme, phenylalanine. And so if you're exposed to phenylalanine, which all newborns are, whether they're on breast milk or formula, you're not able to digest and use that amino acid. And so a toxic substance builds up in your body, and this leads to irreversible neurological damage. So I'm a clinical geneticist by training. And so what you often see in the genetics clinic is a family who might have more than one sibling who's affected. And often the older sibling has a severe form of the disease. And then because we know about that older sibling, we're able to diagnose a younger sibling and intervene early. And this is exactly what this picture shows. So with phenylketonuria or PKU, if you modify the diet of that newborn, you're able to prevent the poor outcomes and the consequences of having this disease. So you can have a normal intellectual development, you can have a healthy life, as long as you stay on a diet that limits your exposure to the amino acid that PKU causes you not to be able to handle. So researcher discovered that by taking a small drop of blood from a heel stick, and that's what you're seeing in the little picture on the screen. So we're actually taking a blood sample and putting it onto a filter paper card, and then we're looking at the measurement or the amount of phenylalanine in the newborn's blood. If the amount of phenylalanine is too high, then we know that the baby may screen positive for having PKU. So PKU was the first test to be added and tried out in a population basis. So it was something that when the baby's born, they look perfectly healthy. But if you look at the molecular markers, you're able to tell that they have a disease where there's a relatively easy fix, which is a change in diet. I know individuals who've grown up on this diet, and it's not something that's easy to do, but if you're able to stay on diet and take supplements, then you'll have a normal and healthy outcome for intellectual development. So as we've learned more and more about the 10,000 or so genetic diseases, we have understood that we can expand the newborn screening panels beyond PKU. So as we understand more and more about things like hearing loss, cystic fibrosis, heart disease, we're able to begin to screen newborns for those diseases as well. And so the hallmark of adding things to nationwide screening is, will the newborn benefit? So we look at whether or not pre-symptomatic diagnosis makes a difference. So if we identify these babies before they show signs of illness, we intervene with either an intervention or a drug or a therapy or even a surgery, will we improve outcomes? So at a national level, we have a federal advisory committee and research groups that look at the world of 10,000 genetic diseases and say, which of those 10,000 might be a fit for newborn screening. We don't think about this in a state-by-state or even a case-by-case basis. We think about it in a population-based way. So one of the things that we need to do in newborn screening is to conduct population-based research. So we need to look at not tens or even 20s of newborns as we're thinking about adding new conditions to nationwide screening. We think about hundreds and thousands and even tens of thousands of newborns that we want to be able to screen to see whether or not newborn screening is a fit for that particular disease. Again, presidents have played a really large role, as well as Congress and even state legislatures, in advancing public health genetics. And this is never more true than in the world of newborn screening. So in 2008, President George Bush, at the time working with Senator Hillary Clinton, passed a Newborn Screening Saves Lives Act. And what this act in 2008 did was it put funding behind 3 agencies at the federal level. And each of those agencies was tasked with doing something different related to newborn screening. So we had the Centers for Disease Control, who were tasked with looking at how the state laboratories function and how they conduct their testing for newborn screening. There was funding to the HRSA to actually look at the implementation of public health genetics and surveillance and care for newborns that were identified with the condition. And there was funding that went to the NIH to think about this universe of 10,000 genetic diseases and begin to do the basic and translational research projects that could sort of tell us which of these conditions are ready to add to nationwide screening. This act was reauthorized in 2014 by President Obama, and it's actually up for reauthorization right now. So I encourage you to Google Newborn Screening Saves Lives Act, and you can email your state legislature and your national senator and congressman to urge them to pass and reauthorize this Newborn Screening Saves Lives Act. On the research side, what the Newborn Screening Saves Lives Act did, as I said, it charged NIH with conducting research studies that would help us think about the kinds of conditions where if we identify the newborns early, we can make a difference in their health outcomes. And so with the funding to the Eunice Kennedy Shriver National Institute of Child Health and Human Development, they created the Hunter Kelly Newborn Screening Research Program. The goal for the Hunter Kelly Newborn Screening Research Program is to discover new technologies to conduct the screening on a population basis for disease, to help develop new treatments and new interventions for the diseases that we screen for, to be able to provide research and data for conditions that we think are sort of ready for nationwide screening, and to conduct pilots of these conditions. So when we think about conducting a pilot, this is where we begin to enroll newborns and test them for a condition that's not yet screened for. So we might do a pilot of 80,000 newborns to understand, are we going to find 1 or 2 or even 10, depending on the incidence of the condition, where we can intervene early and make a difference in that newborn's life. This research program was named after Bill Kelly's son, Hunter. So Hunter had a leukodystrophy called Krabbe disease. He passed away in early adolescence, but we know that if you screen for Krabbe disease in some newborns, the treatment, which is a stem cell transplant, can make a difference in their outcomes. So that was why we call it the Hunter Kelly Newborn Screening Research Program. As part of the Hunter Kelly Newborn Screening Research Program, they're focused in several different areas. They're trying to understand the application of sequencing the whole genome in newborns, and whether or not having that information helps us think about what a newborn might be susceptible to, not only in the neonatal period, but also as that newborn grows up and goes through childhood and adolescence and even adulthood. So obviously that helps us think about some ethical, legal, and social issues about identifying conditions in newborns and in young children that maybe aren't immediately medically actionable, but that point to a future susceptibility. So we're not ready to add genomics to newborn screening yet, but we want to do the research and we want to do the ethic and LC studies so that we can understand whether genomics adds any value in the newborn period. The Hunter Kelly program is also focused on natural history and health outcome studies. So this is where we follow newborns who have a condition over their lifespan. We collect information from the clinicians, from the schools, from the public health programs to really understand how these newborns who are born with these conditions do throughout their lifespan, and if there's anything we can do to improve the care and the outcomes across the United States. This program also thinks about new conditions, something like spinal muscular atrophy, where we think about, this is something that now that we have a gene therapy, which we never had before, that you can actually intervene with these newborns in the first year of life. And so we want to be able to try that out. We want to be able to do population-based pilots and screen newborns for SMA and then try out the treatments and see whether or not they make a difference. We also want to conduct long-term follow-up or LTFU studies where we follow longitudinally and prospectively newborns who are born with conditions that have been recently added to nationwide screening. So Pompe disease, mucopolysaccharidosis type 1 or MPS 1, X-linked adrenoleukodystrophy, and spinal muscular atrophy are the most recent conditions to be added to nationwide screening. And so we want to be able to collect information on the newborns who are born with these conditions to see whether or not identification through newborn screening made a difference. The Hunter Kelly program also funds the NBSTRN, and that's what my main job is at the American College of Medical Genetics and Genomics. So I'm the co-principal investigator of the Newborn Screening Translational Research Network. At the NBSTRN, we are funded by NIH to create resources for researchers and public health partners who are invested in advancing newborn screening. So we work with clinicians who take care of these newborns. We work with researchers who invent the new technologies to screen and diagnose these newborns. And we work with researchers and industry for the folks who design the new treatments and interventions for newborns with these conditions. We build databases and systems to collect information across the United States on a case-by-case, population-by-population basis so that we can begin to understand the real value of public health genetics with newborn screening. And so we're building this system. We're in our 12th year of operation. You can check out our website at nbstrn.org. We're actually in the middle of building a new website. So this summer we'll be launching a new website. So stay tuned for that and check back often with us. So I'm going to go through a few of the things that NBSTRN focuses on and how we take advantage of our partners in public health genetics. So we operate what we call the Coordinating Center, or the CORE, at the ACMG. Over the last 12 years, we've built a network of experts who are experts in caring for individuals with rare disease, experts in genetics and genomics, experts in public health, and experts in ethical, legal, and social issues. We have a network of experts that totals about 400 individuals across the United States that come together in focused efforts to help us think through the types of support that we can give to researchers so that we can make sure that the basic and translational studies that are needed to advance newborn screening actually happen. So if we think about today, at a national level, we recommend screening for 61 conditions. So 61 is a lot different than 10,000. So we think our universe of genetic conditions is somewhere around 10,000. So you can see we've got a long way to go to understand between 61 and 10,000, which of those 9,000 or so conditions might be a fit for newborn screening. The thing that tips the scale to have us want to add a condition to newborn screening is that now we have a treatment for it, or now we have a way to actually screen for it. So when we look at the candidates for newborn screening, sometimes we need to do targeted research studies to invent new technologies, or to invent new treatments, or to invent new interventions. And another thing that we do in addition to kind of thinking about what should be part of state newborn screening, we try to help research teams and clinical teams work with the state programs to follow the children that are currently screened and diagnosed with conditions. So we operate what we call a virtual repository of states, subjects, and specimens. And this virtual repository gives researchers a snapshot into each of the state newborn screening programs, tells them who to contact within each state if they want to obtain a biospecimen to conduct research on, and gives them an idea of, in each state, how many cases of each of the conditions that are part of newborn screening are born in each state each year. So we're trying to help researchers find subjects and find specimens to conduct their research. We also operate what we call the Longitudinal Pediatric Data Resource, or the LPDR, where we support research and clinical groups in following newborns with conditions over the lifespan. And we operate a newborn screening research repository where we collect information and display information on the conditions that are part of newborn screening and the candidates that are part of newborn screening. So this is just a snapshot of our new website. On our new website, we focus in 3 different areas: on a researcher network, our NBSTRN network, and a family and parents network. So we know historically in newborn screening, families and parents have been so important. It has been the advocacy of parents, patients, and families that have really led to the expansion of newborn screening and the harmonization of newborn screening across the United States. Just a decade ago, we had such a disparity across the United States between the number of conditions that were screened. We may have seen in the early 1990s that in California, they may screen for 60 conditions, while in Iowa, they may screen for 3 conditions. So that obviously led to some health disparities. And one of the things that the Newborn Screening Saves Lives Act did was put funding behind some evidence review processes so that we could sort of level the playing field and give states a national recommendation for what they should screen for. So did some of the homework for the states to say, here's what we think meets the evidence bar or has enough evidence that we can say that early pre-symptomatic identification and early treatment makes a difference. So this is just a screenshot from our website where we focus on PKU. You can see that we, based on the incidence of PKU, and every state in the United States screens for PKU, we think there are about 400 babies that are born with PKU every day or every year. So if we could follow those 400 babies over time, we would learn more about the disease. But you might ask me, well, gosh, Amy, PKU has been screened for 60 years. Don't we understand everything that we need to about this disease? And the answer is a resounding no, we don't. Although we can say that over 98% of newborns are offered a newborn screening test and receive the newborn screening, we don't have any national database to say, how are these newborns doing? Do they stay on diet? Do they maintain their gains in intellectual ability? What happens when a female with PKU gets pregnant? Is there something that happens with her diet or with her IQ? We need to have these long-term follow-up databases so that we can not only understand how a newborn does when we identify them early and get them into treatment, but how individuals do over the lifespan. And that's really one of the things that the National Coordinating Center for the Regional Genetics Networks focuses on, is this public health surveillance and thinking about how individuals manage genetic disease over the lifespan. So I would encourage you to check out the NCC's website and to read more about their efforts across the United States to make sure that we're beginning to understand how to optimize the care and treatment of individuals living with these different conditions. One of the new tools that we've been working on for our new website, we call the Newborn Screening Research Repository. And we're really beginning to think about how do we support researchers who are interested in advancing those 9,000 or so diseases that aren't yet part of newborn screening to understand which ones might be a fit for that. We also operate the Longitudinal Pediatric Data Resource. So I always use this picture and think about newborn screening really begins prenatally with an OBGYN or physician talking to a pregnant couple about here's what's going to happen after your baby's born. There's going to be a small amount of blood taken, or they're going to get a hearing screening or a pulse ox screening for heart disease in the newborn nursery. And then we're going to look for currently 61 conditions. All 61 conditions are not curable, but they are treatable. And so many of the newborns that are born with a condition diagnosed through newborn screening, and we estimate that there's about 20,000 newborns a year that are born with one of these conditions. Each one of those newborns enters into a series of clinical care assessments and long-term follow-up. And so this gave us the opportunity at the NBSTRN to start to think about, if you could follow these newborns over time, what kinds of questions would you ask? Would you ask about their height and growth and development? Would you ask about their behavior? Would you ask about how they're doing in school? What kinds of information would you want to ask if we could wave a magic wand and follow each of these 20,000 babies every year, with the goal of improving outcomes for all newborns. And so if we think about these longitudinal records, it's really thinking about from birth all the way up to throughout the lifespan and adulthood, beginning to capture information. So in the beginning, we might think about family history, whether or not this disease or condition has ever been seen in the family. We think about the race and ethnicity of the parents. We think about the particular genotype or misspellings in the genome that led to the condition. We think about anything that happened either prenatally with the mother's or the fetus's health, or anything that happened neonatally, whether the baby was born too early or underweight or had an injury at birth or ended up in the neonatal intensive care unit. So collecting all of this information over time, we're able to get a picture of how these individuals grow up and how they do with living with these different genetic conditions. So the real benefit of public health genetics and newborn screening is that we're able to look at almost all 4 million babies. All 4 million babies get screened for 61 conditions. The 20,000 that get diagnosed through newborn screening, if we were able to follow them over time and collect all of this really rich information, we could really begin to understand health outcomes and begin to understand across the United States, where do we need more neurologists to care for babies with spinal muscular atrophy? Where do we need more audiologists or speech and language professionals to work with newborns who have hearing loss? Where do we need more surgeons that can help with correcting heart defects? So it really helps us think about the healthcare workforce and how to improve outcomes for these individuals and families. In the NBSTRN team, we're heavily focused on data collection and data analysis. So when we have the opportunity to follow newborns, whether it's for one condition or all conditions that are part of newborn screening, we want to collect as much information as we can. But we also want to turn that information into pictures so that we can work with our public health partners and clinicians who may not have training in epidemiology or statistics or even genetics and genomics. We want to enable them to help us understand the results and what we're seeing over time. We want to be able to look at the conditions that aren't yet part of newborn screening and begin to say, if we intervene early, are we making a difference? And if we intervene early, what does that mean to the healthcare workforce? So in the beginning with PKU, as I said, that's a change in diet, not to minimize what that change in diet and getting a medical food and changing a diet, that's a real impact on a family. But if we fast forward from when PKU was added in the 1960s to newborn screening to the conditions that are being added today, the conditions that are being added today require hospitalization for many months, stem cell transplants, gene therapy, sedation of a newborn in an operating room where we do intrathecal injections of an enzyme for spinal muscular atrophy. So the interventions on the medical side are much more intensive for the conditions that have been recently added to newborn screening. So that obviously has an impact on our healthcare teams and on our ability to provide the best care across the United States. So one of the roles at NBSTRN in partnership with NCC and other groups at ACMG is to think about how do we employ the best practices? How do we make sure that pediatricians are able to care for individuals with rare diseases and with really complicated interventions that are now becoming sort of routine across the United States? So at NBSTRN, as I said, we're working on a new website. Hopefully that'll launch this summer. We would love to have all of you log in to our current website, learn a little bit more about what we do. We operate monthly webinars where we bring together state newborn screening programs, researchers, clinicians, parents, and families to think about the conditions that have been recently added to newborn screening. And we're beginning to expand our network so that we're not just working with clinicians who are on the front lines caring for these newborns, but we're also expanding into things like speech therapists who are working with these kids in the school setting, or behavior therapists. As we expand the number of conditions that are part of newborn screening, we're beginning on the research side to reach into new disciplines in healthcare, because we need to make sure that all of these babies, and as they grow up into adolescents and adults, are really benefiting from the best in medical care. We have several partners that we work with across the United States, in addition to their NCC that's operated out of the ACMG. We work with partners that are funded by HRSA. There's a program out of the American or Association of Public Health Laboratories, APHL, called New Steps. And New Steps is focused on giving support to state programs. So as I think about our role in research, NBSTRN plays a big role in the beginning of this picture, where we're really thinking about what conditions could be part of newborn screening, what kind of studies do we need to do to have them be part of newborn screening, and to make that evidence case. And then once we get all that data figured out and collected, then we can translate that information to our partners at New Steps. So as something says, yes, we're ready to do nationwide screening, a pilot has been conducted, we know that we can prospectively and pre-symptomatically identify newborns with a condition, then we can hand that information over to New Steps so that they can begin to work with and support the states in implementing screening for these conditions. The newborn screening public health laboratories have a system of laboratory analysis, short-term follow-up, and long-term follow-up, where their goal is to screen newborns. Several thousand dry blood spot cards come into the laboratory every day. They're immediately tested for 61 conditions. Those results are shared with the pediatrician and other clinical care providers, so that these individuals and newborns can get directly into care. One of the goals of newborn screening is really to recognize the urgency. So if we urgently get these newborns into care, where we can, before the symptoms show up, provide a treatment or intervention, we know that we can prevent the consequences of these disorders. After APHL sort of does their work with implementing newborn screening at the state level, then NBSTRN plays a role again, where we conduct these longitudinal studies where we follow these newborns over time to really understand how they're doing. A good example of this is sort of that start to finish is we're currently conducting a newborn screening pilot of Duchenne muscular dystrophy. So in the pilot, NBSTRN is leading an effort to develop a test to screen for Duchenne muscular dystrophy. We're looking at, once a baby screens positive, what kind of DNA testing or molecular testing is needed to support the diagnosis of Duchenne, and then to work with clinicians who are part of the pilot to intervene with these newborns before they show symptoms. So the average age of diagnosis for Duchenne in the United States is anywhere between 3 and 5 years of age. But we know that the consequences of Duchenne begin prenatally. So by the time these individuals show weakness in their muscles, they've already had irreversible damage to their muscles. So the idea of newborn screening is to intervene with therapies and treatments before there's damage to the muscles, as soon as possible after the baby is born. So the reason that Duchenne, and we see this a lot with, you know, the 9,000 or so conditions that aren't yet part of newborn screening, it often takes a new discovery to lead to change a disorder from being a genetic disorder into a candidate for newborn screening. So with Duchenne, there was the discovery and FDA approval of new therapies and management strategies, and the FDA approval of a screening test. And so because of these two factors, it sort of moved DMD up into the priority list for newborn screening. So NBSTRN and ACMG worked with the Parent Project for Muscular Dystrophy and the New York State Department of Health Newborn Screening Program to develop a consortia approach to conducting a pilot for Duchenne. And by this consortia approach, we mean that we brought together industry to support this effort. So we have individuals from the pharmaceutical industry as well as the device industry who play a huge role in newborn screening by advancing treatments and screening technologies. And they are funding this multi-million-dollar 2-year pilot of Duchenne muscular dystrophy. We're enrolling mothers and families and in 2 hospital systems in New York State. We were enrolling in the hospital, but because of COVID, we're now enrolling after the newborn goes home. And so we've had to change some of our protocols, but so far we have 12,000 newborns that have been screened for Duchenne. We have about 10 that have screened positive and a few that have gone on to a diagnosis. And so what we're trying to do is we're trying to collect the information where then we can put together what's called a nomination package to submit that to the Federal Advisory Committee for them to do a review and say whether or not newborn screening for Duchenne muscular dystrophy should be a priority in the United States. This is just a bigger picture of some of, it's a lot of detail on this slide, but you know, it sort of shows all the different partners that NBSTRN works with as we think about these disorders. Duchenne is a new area for us because we want to really think about the development of muscles, but also the development of the intellectual capabilities of these individuals who are screened early and intervened early. So we want to understand, if you treat these newborns early, does it make a difference? NBSTRN's job on this pilot was to engage with clinical experts and to build what we're calling the DMD NBS cloud, where we can gather all of the information, whether it's genetics or parent perspectives, family history, newborn screening laboratory results, and clinical findings over time to understand how these newborns are doing. At NBSTRN, we've built this system of information technology. You can imagine, because we're following tens of thousands of newborns and we want to collect information that's personally identifiable, we have to go through a certain approval process at NIH that we were able to collect identifiable information like visit dates. So you often think of personally identifiable information as being names and addresses and maybe even genotypes, but it's also visit dates. So obviously, to follow a newborn over time, you need to know what time did they get, when did they get the MRI, when did they get this treatment, when did they get this intervention. So you need to follow personally identifiable information. So to be able to do that, NBSTRN has gone through a multi-year process and approval process at NIH so that we are approved to collect identifiable information. That means that every piece of information that comes into our systems is consented, is IRB approved and reviewed by external groups, and we really take seriously information security and how the information is used. But one of our new goals with our new website is to not only make sure that we're good stewards of the data and we're taking care of the data, but also to make the data available to different groups. So we want to make sure that as we're collecting these millions of data points, that they're also available to public health researchers like you, so that you can log in, you can look at aggregate data, de-identified data, and maybe ask new questions of the data. You might want to say, how many babies in this zip code area or this region of the country receive this intervention and do well in school? So there may be some public health questions that you can use our data that's accumulating at NBSTRN to help advance your own research. This is just a summary of some of the things that NBSTRN does, from the longitudinal collection of data all the way through thinking about the ethical, legal, and social issues related to working with these vulnerable populations and working with genomics and genetics. So with that, I'll end our talk today and turn it back over to Dr. Chan. Feel free to check us out at nbstrn.org, and thank you everybody for your attention today.